So here we see a toxic erythroderma or erythema that my friend Dimo Papagiannis sent me, E. multiforme, and the E. nodosum on your right. This was actually a reserve pilot for the National Guard, an F-16 pilot, and she just had enormous pains in her legs. She also had desert rheumatism or arthralgias, and all she wanted to do was go back to flying. So she was otherwise well, but had this really, really painful lesion on her legs in association with a focal pulmonary infiltrate. So I mentioned desert rheumatism, and this often goes hand in glove with the rashes of E. nodosum and E. multiforme. And these are either arthralgias, more rarely an arthritis, that's associated with a pulmonary infiltrate. And some years ago, I was seeing one of the nurses at the VA hospital, and she had a terrible wrist arthralgias in association with E. nodosum, had no pulmonary symptoms, but in fact, when we got a chest x-ray, she had one and she had a positive serology. So again, these are things that should really tip you off. They probably only occur 5% of all mnemonic cases, but if you see them, you really want to think that if you're in the endemic area. Obviously, there are a lot of other causes of E. nodosum and E. multiforme, but in the mid-portion of Arizona, cocci is going to be the major etiology. So I want to mention chronic fatigue. We did a study, Jennifer Bowers was a nutritionist I work with, and she actually did this for her PhD, and we just kept seeing all this fatigue in our clinic. So we decided, well, let's see if we can't quantify it. So we actually used a multiple sclerosis scale and took patients, 48 symptomatic patients with cocci, and applied this scale. And we found that 65% by this scale had significant fatigue as measured. And what was different, we actually did a control group of just general veterans patients. And I don't know if I was shocked or not, but they were also very fatigued. And as maybe I am. But there was a difference. Those with valley fever not only were fatigued, but were losing their body mass index was going down. So they were losing weight and fatigued, while the other group, while they were fatigued, and they were less so fatigued, but they were fatigued, but they were gaining weight. So loss of weight in association with fatigue should really trip you off. Now, the fatigue does get better. And as we measured it over time, and as I've seen this in clinic, patients will get better. And the way I usually ask about it is not, are you better today than yesterday, but to ask week by week and even month by month. And it's just amazing how patients will tell you, oh, I'm definitely better than I was 2 weeks ago. So the fatigue slowly gets better. We were never able to identify any factors associated with the fatigue. That is, you could have this with a fairly benign course or a severe course. So fatigue seems to be a general factor, and I do think it's worth asking about. So let's talk about the chest radiograph, because I think there's some points, again, that should tip you off for a patient. So usually the pneumonia one sees, or the process in the lung one sees, is focal, and it may be upper or lower lobe. So we have a rule when I consult is that any upper lobe pneumonia I see, certainly in the hospital, is not a community-acquired pneumonia. And that's a good rule to go by, because community-acquired pneumonia is by definition an aspiration, and people aspirate into their lower lobe. So if you're seeing anything in upper lobe, that should give you pause. And I've just seen that ignored by non-infectious diseases clinicians, and we always come by and say, there's something unusual here. Now, a lot of things give you upper lobe pneumonia. Of course, the classic is tuberculosis, and that's because of oxygenation in the upper lobe. Tumors obviously can be in upper lobe, and you can get an obstructive pneumonia in the upper lobe. Why cocci may occur in the upper lobe, I don't think has ever adequately been explored, but it certainly occurs there with some frequency. The other things to look for, often these pneumonias are extremely dense radiographically. As I mentioned, they're upper lobe, and the other trick is they often cause hilar or mediastinal adenopathy. Now again, when people look at radiographs, frequently don't focus and look at the adenopathy. But if one does and one sees that, that's a tip-off because, again, bacterial pneumonias do not cause adenopathy. So here's some examples. This is actually an African-American man who developed this pneumonia in January. We can see there, and it's upper lobe. And we also see that there's some adenopathy there. Now, he wasn't diagnosed until several months later. I think a serology was finally obtained, and he remained symptomatic. So he came back, and here, now 3 months later, we can all see he's already improved. But he still has some evidence of adenopathy. So this would be a pretty classic, and I think if one looks at all of these, let me see if I can reverse this, you can see just how dense this initial infiltrate is, and then if you can look, you do see that adenopathy there. And if you have trouble seeing it, just always go to the radiologist and specifically ask them, even on a plain chest x-ray, do you see adenopathy there? So this is a fairly classic case of primary pulmonary cocci. Here's another one, and this is a case we saw years ago in consultation, and this patient had already been on 4 different antibacterial agents by the time we were asked to see him. And again, you can see this very, very dense left lower lobe infiltrate in association with adenopathy. This patient also had peripheral blood eosinophilia. So there were all these hints that this could be coccidioidomycosis, which indeed it was. Now, that's the usual kind of primary pulmonary coccidioidomycosis, which is focal. But occasionally you'll see diffuse, or sometimes we call it miliary pulmonary cocci. Now, just to back up on the term miliary, it's one I don't like because it really is a term we use for overwhelming pulmonary tuberculosis from a mycobacillemia, and it comes from the term millet seeds, which are 1 to 2 millimeters, and actually cocci doesn't do that. So another term for these are reticular nodular, where you just see nodules and streaking. These occur in two distinct flavors. The first is in highly immunocompromised patients. So prior to effective antiretroviral therapy, this was a common presentation of coccidioidomycosis in an HIV patient who was highly immunosuppressed. With diffuse disease, it often mimicked pneumocystosis and often occurred with pneumocystis so that they were co-infected. But it also may occur from high inoculum exposure. And interestingly enough, that has been the most frequent cases we've seen in the last few years. And as Rebecca mentioned, archaeology remains a unique risk factor, probably because in certain sites there's a very high inoculum exposure. So here's diffuse pulmonary cocci in an AIDS patient. This is actually in Mandel, the infectious disease text that John Galgiani wrote the chapter for. And again, we can just see this diffuse process with kind of both very small nodules and streaking, and maybe due to other etiologies. Here's a case from Bob Larson, though, from many years ago, from 1985. He reported 2 cases in archaeology students. And here's day 1 when this one archaeology student came in with just has these large, almost nodular lesions. And then by day 4, you can see these have become diffuse and extensive. And if you look closely, you can see the radiopaque line of an endotracheal tube. So these patients often do very poorly, need to be intubated. And they're very difficult because often their serology is not positive on initial presentation. There's nothing unique. This can look like ARDS. Frequently, we make the diagnosis by culture, and that takes several days. And this has a significant mortality associated with it. So when should we suspect coccidioidal pneumonia? And I've kind of mentioned the things I think about. And again, I acknowledge that clinical studies frequently or don't come out with these factors, but as a clinician, I've noticed them. And the first is on the history. Does the patient have fatigue, headache, night sweats, and weight loss? So again, if you're seeing a patient, particularly with a persistent process, it's worth asking about those factors. Secondly, we look at the x-ray. Is this upper lobe, is it dense, and is there hilar or mediastinal adenopathy? If those factors are present, that should really make you think of valley fever and not a bacterial process. And then finally, probably one of the most common reasons I might see a patient is because they failed antibiotics. And so I'm asked, well, what next antibiotic should I put this patient on, Dr. Ampel? And the real answer is, well, what really is causing this mnemonic process? And so that is, so if the patient keeps failing and has been through a couple courses of antibiotics, that certainly should give you pause. And then I mentioned already once is peripheral blood eosinophilia. We're not quite sure why eosinophilia occurs in coccidioidomycosis. Sometimes one gets even tissue eosinophils, but it does occur, and it occurs with enough frequency, probably in at least a third of cases, that to see it, it's the first thing we always look for. We just look at that differential on any of these mnemonic cases, and if there's peripheral eosinophilia, say 7%, that's, you know, again, you're not going to see that with a bacterial process that should really make you think of valley fever.